So why 70 MRI is a major step forward? It's better we have it's because we have a better signal to noise ratio, so a better contrast and a better resolution. That means, from the clinical point of view, that we can have a gain of detection of lesion, particularly when they are not apparent in at 1.5 and 3T, like here, this focal cortical dysplasia, which for epileptologists or neuroclinicians, it's clear here and very, very nicely seen at 7 Tesla. That's also a mean to better analyze small structures, for example, cerebellum, in terms of foliation in the vermis. And very interesting from the pediatric point of view, that may require less acquisition time for sequencing. But when we increase with the field, we also increase some limitation, particularly higher sensitivity to movement due to the higher resolution. And also we can increase heterogeneity of the images, so have a loss of signal in some local area. So Vincent Gras, just after me, will explain how it's probably possible to solve these disadvantages. Anyway, due to this added value, there are today, from 8 years, a lot of research studies performed in patients versus controls, in adults, in all different types, very various types of neurological and also psychiatrical disorders. And several 7 Tesla machines are entered at the hospital in the US, in Japan, in Europe, in France too. But okay, sorry. No. Okay, thank you very much. So these 7 Tesla machines are not yet completely approved, particularly in children before the age of 12 years, because of a particular safety reason still incompletely studied in children, which is the fact that the temperature of the tissue may increase. And we can measure that with what we call SAR, specific absorption rate. So Vincent will explain that to you. In terms of what we are today, so in terms of safety issue, we are going on, that's in progress. Again, Vincent will explain that, and our colleagues from Utrecht are well familiar with that, probably. Because we now can measure SAR or simulate SAR in neonates. For children, there are quite a few things, but that's in progress. You have here the all exhaustive series reported in children at ages before 15 years. So you see mostly 2 types of pathology, epilepsy, and not pathology necessarily, but neonates and infants before 3 months of age. I won't talk about these studies before 12, from 5 years, because there are only partial exploration using only spectroscopy, MR spectroscopy. Although these studies have quite important samples and also controls, so normal, typical children. as far as the complete exploration is performed, so we are for the moment limited to epilepsy and to neonatal period in different teams. And here you have the number of children before the age of 12 or 15 explored, to see very few. What is the added value? So for epilepsy, particularly in temporal lobe epilepsy, so we have again to analyze hippocampal structure. Here is a result of a project we have here, which is now finished in NeuroSpin, ePlay, when you can see very clearly what we gain to visualize the structure of the hippocampus. For epilepsy, what we call extratemporal lobe epilepsy, the best candidate for lesion, that's cortical focal dysplasia. So we can see better the lesion and also the cortical folding around. And finally, that's an image in neonate where there is an increase in the visualization of the variants. So finally, for the project in NeuroSpin, we decided to focus on these ages, non-neonates. We are not specialized for CT in this population. So we focused on that in children age more than 6, so from 6 to 18 years, and to make a translational project for methodology, instrumentation with parallel transmission. So again, Vincent and the team of methodology will explain that to clinics. And we will focus on 2 specific populations of children, including controls, so typical children that will be new at this age, mainly because we have an expertise in clinics and imaging in these 2 types of pathology, and also because there is a rationale very important in the epilepsy and fetal alcohol syndrome. So very rapidly, the rationale for epilepsy, there are a lot of things in adults performed at 7 Tesla MRI for epilepsy, but in a focused part of epilepsy, that means patients candidate for surgery with a focal lesion, what we call focal pharmacoresistant epilepsy. So the mean, why? Because the diagnostic gain of the lesion with compared to 3T MRI is about 1/3 more. And there are also recommendations for use in clinical practice at 7 Tesla with an epilepsy task force, but mostly for adults. So although this problematic is firstly a pediatric issue, as you can see here from this very, very large population of surgery epilepsy, the age of onset of the different type of surgery epilepsy, so with lesion, temporal lobe epilepsy, mainly extratemporal lobe epilepsy with malformation of cortical development. See the age of onset, that's very early in life. So in children, that's a problem of neuropediatricians, neuropediatrics. But surgery is always later. And why? Mainly because, mostly because MRI is non-contributive at 3T, or maybe non-contributive is almost one half of the patients. And from this study, we know that earlier the surgery, better the prognosis. So that's really, there is a need, unmet need for imaging in this particular epilepsy. And we decided to focus for this project on this part of malformation of cortical development, surgical epilepsy. And the second population is exposure, fetal exposure syndrome, or fetal exposure, to alcohol. The purpose of David and his team is that when the complete pattern, clinical pattern is present, like here, the diagnosis is complete, so fetal alcohol syndrome is certain with the facial dysmorphy, growth deficit, and so on. But often, all these pattern is not present, and we lack of marker, diagnosis marker. So they studied something complementary to what the first Catherine presented this morning, which is cerebellum, which could be a good structure candidate for 7 Tesla. First, from the morphological point of view, with the foliation, which could be scored from normal to completely abnormal, and also from the volume point of view of the structure of the cerebellum, particularly the vermis, and particularly using this type of analysis Jean-François spoke just before, allometry, and they discovered that the anterior part of the cerebellar vermis could be a good candidate as a diagnostic marker for this syndrome. But what is not remain a question open is that this anterior part is mainly sustaining motor function, and in fetal alcohol syndrome, they have no motor disorder. So why? So finally, we will study not only the morphological point of view, but also the function to test these questions with this protocol, which will be made on performed on the MRI 70 here, using our expertise in neuropediatric exploration. After, safety and feasibility will be preoccupied by Vincent and me.
Thank you, Catherine. So let me show you a bit of the strategy in TRANSEPT from the point of view of the acquisition. So as you all know, and as Catherine already said, SNR 7 Tesla is very attractive from the SNR point of view, because as compared to 3T, there is a gain of a threefold gain in SNR, as you can see in this image comparison made by Alexandre Vigneault some years ago. But 7 Tesla also comes with the problems of RF field heterogeneity. As you see in this T1 weighted acquisition, you have a very poor signal shown on the left, and also a central brightening effect. A very poor signal also at the center, because you suffer in these acquisitions from the central brightening effect. If you look into the physics a little bit of this acquisition, you can map the transmit RF field, which is shown on the top, and you see a very good correlation between the transmit field distribution and the deficit of the image below. So 7 Tesla with the same hardware type as used with, at 1.5 Tesla and 3 Tesla is going to fail. It's not really possible to fix this problem, and we need to complexify a little bit this hardware. And this there was a major step forward with the proposal of the parallel transmission hardware decennies ago, which allows you to independently control the transmitting RF elements. And with this, it is possible to play different RF pulses on the different transmit element of the coil, and it is possible to recover a very uniform excitation profile as you have at a field strength that is below 1.5 Tesla. So virtually you have this time a 7 Tesla machine with the capability to uniformly excite the spins across the brain. If you apply this technique for T1 weighted imaging at 7 Tesla, you have on the left the standard acquisition without parallel transmission, and compared to it, the similar acquisition performed in parallel transmission with optimized RF pulses. And you see a very clear amelioration of the white matter to gray matter contrast with this parallel transmit enabled acquisition. And this is what we wanted to bring into this TRANSEPT project. You have to know that since 2010, we invested a lot of effort into the parallel transmission technology. We have a team that developed specific RF coils to benefit from this advance. And this coil is shown in a photo here. And you have also on the left the schematic of the coil. And so this development was made for 7 Tesla and even for the new 11.7 Tesla. So in TRANSEPT, we take advantage of this long-term development, and we take a 7 Tesla Avanti 2 homemade RF coil for our acquisition. And we have recently shown that we are able to do anatomical imaging with high resolution with this coil. You have here on the left standard T1 weighted acquisition with a resolution of 0.8 millimeter isotropic, and on the right side T2 weighted 3D acquisition or T2 space with the same resolution, and with acquisition time that is very attractive for scanning subjects. For another type of application, we want to look into the cerebellum in particular. We have tried 3D types of acquisition on the left, 2D types of acquisitions to look into the vermis of the cerebellum, also the 2D turbospin echo of the vermis with a high resolution in plane, and also 3D EPI acquisitions to do fMRI studies in the future. And this is here an analysis made out of 500 shots, 500 fMRI shots in 5 minutes, just to a sanity check to see that we have the sufficient quality to discover or to rediscover the default mode network in a resting state fMRI experiment. So to sum up, parallel transmission is the best solution as far as I know to remove the V1 artifacts that we have at 7 Tesla, but it requires specific hardware. It is complex to use, and this is the point that I want to develop a little bit with you. It is in terms of RF safety, it is not transparent because we need a PTX specific local SAR monitoring to run safely parallel transmission acquisition in parallel transmission mode. So this has shown long ago, the SR distribution first is dependent of the head anatomy. In this review paper, you can see that the SAR distribution in the head is dependent of the mass of the subject. This has been shown more recently, more specifically for pediatric scans by Malik and colleagues. That the SAR distribution in the head is dependent of the mass of the subject. He has looked into the peak SAR and the head SAR and was able to show that in fact the head SAR was slightly increasing as the mass was decreasing. But this study was done for signal transmission, and we want to use a parallel transmission. And with parallel transmission, as shown in this small video, in fact, the distribution of SAR, so RF energy deposition, is actually dependent of the RF pulse that you are playing out. So we need to redo this complete analysis by taking this additional complexity into account. And we have spent a lot of time to develop the mathematics behind to be able to maintain the same level of safety of the MRI scans when we are using parallel transmission. So I don't want to, for the sake of time, I don't want to go into the details of this, but I want to show that this is something that's now solved, actually. And for the validation of these mathematical models, we can resort to the MR thermometry technique, where we are able to actually measure in a phantom, so in an object, the positions of the SAR hotspot, or we can map actually the increase in temperature after applying RF pulses for a duration of, say, 5 minutes. And this is very important to really validate our methods and to prove that we maintain a safe acquisitions. So to conclude, the TRANSEPT project will be the first protocol in NeuroSpin recruiting pediatric patients below 12 years for a 7 Tesla MRI scan. In this protocol, the use of parallel transmission was put forward to really gain in quality, to have the highest quality at 7 Tesla. The use of a homemade parallel transmit RF coil was for us necessary to be able to build our local SAR model to ensure patient safety. We have done experimental validation of the RF coil that has been developed and built in NeuroSpin. And we plan also on applying motion correction strategies to be more immune to involuntary head motions during the scans, because we have children with children in the scanner. We expect the attrition rate to be higher otherwise. With this, I would like to thank all the teams in NeuroSpin that contributed to this, and I would like to thank you for your attention.